Welcome everyone to what is increasingly now our new normal with webinars for the PPA support group. I think I've met or had interactions of some kind with most of you before, but I'm Jason Warren. I'm one of the neurologists at the Dementia Research Centre in Queen Square in London, and we run a clinic and a research program in PPA, and I'm the consultant for our outfit that's been probably most closely connected with the PPA support group over the years. And it's a very great pleasure to welcome you all today. Before I forget, there are always with these webinars some housekeeping things that I need to just let you know about the new world we're getting used to. It's the situation with the Q&A for the question and answer. We have a Q&A later as part of the agenda, but we want questions to go into the Q&A box, and there's an option to submit questions anonymously if you prefer. There's a little box there, post as anonymous, if you can see that, but not pleased to use the chat for questions. This is just so we can streamline things and keep on top of questions as they come in. So please don't use the chat, but use the box. But you are welcome to use the chat box to say hello, make comments about the webinar, but not for questions. That's okay. It's probably, well, in fact, we're asking people not to put, good idea to put personal details into that. Because everyone else can see the chat is the point. We are recording the webinar. So that means, first of all, just to check everyone's happy that that's the case, but it means that if anything gets missed, you don't have to worry. It'll be, you might want to go and make a cup of tea or something. You can always catch up with it later. And there's an RDS YouTube channel 1 week, I think it is, after the live session. So it will be coming. So bear with us, and you'll get a link emailed to you as well through the same contact that we've sent you about the Zoom. And if there are things mentioned, there might be, resources, various things mentioned in the webinar, that'll be shared as well. So, and of course, if there's something else that you want to query, we're always very happy to take emails and queries after the event. So don't worry. We want this to be maximally useful and enjoyable, hopefully, for everyone. So as always, we like to think we've got a useful agenda, an interesting agenda today. So, and some really, really interesting speakers. So what we plan to do is go, without too much further ado, into a discussion of neurological symptoms beyond speech. Now, this is sort of, we like to have themes for the webinars. So when we were thinking about, where we were thinking about a theme for this one, we thought it's been a while since we talked about all the other sort of neurological features that people with PPA get, which is not necessarily primarily their speech and language problem. So that's the sort of the theme. So we kick off with a neurologist talking to us, Dr. Chokesuwattanaskul, who I will introduce formally very shortly. And then we get a perspective of the more practical perspective of care and therapy from a senior clinical physiotherapist. That hopefully will be at about 10 to 20. And then a conversation with Anna and two members of the support group who very kindly agreed, Will and Audrey Barclay. I'll flag them up when we come to them, but they are talking about lived experience, and that hopefully will be at about 10:35. And then there's a brief announcement of some very, very interesting, exciting research that's very closely related to all of you, and I'll explain why I think you can be really helpful with this research. A little notice about that. And then hopefully at around about 11 or just before, we'll move on to the panel Q&A, and that's really the panel of speakers and another senior physio, Claire Craig, joining for that, and some members of the support group as well. So Anna Volkmer, who I think will probably need very little introduction, our senior specialist speech and language therapist, who's very integrally involved with these support groups, and I think I know many of you have met, will be chairing that. So what I will do, without further ado, is move over to our first speaker, and the first introductory session is about kind of the neurological perspective on symptoms beyond speech in PPA. Dr. Chokesuwattanaskul is working with us at the moment, actually, in the Dementia Research Centre, but she's an attending physician at the Neurocognitive Unit in the Division of Neurology at Chulalongkorn University in Thailand. So we have a wide reach with people that we have coming in and helping with the research and helping with these support groups. So very, very happy to welcome Dr. Chokesuwattanaskul, and she prefers to be called Anthipa for purposes of if you want to get in contact or ask questions later on. So I'll hand over to Anthipa now without further ado.
Hi, my name is Anthipa, and now I'm working with Professor Warren at the UCL Dementia Research Centre. Back in Thailand, I also run a memory clinic seeing patients with various types of dementias. The title for my talk today is Neurological Symptoms Beyond Speech in PPA. First, let's look at the big picture of what symptoms may occur in neurodegenerative diseases. This slide lists 4 main categories of symptoms that may occur, which are cognitive impairment, psychological symptoms, behavioral symptoms, and motor symptoms. We can then further categorize the cognitive impairment into subdomains, which are language, memory, visuospatial, and executive function. Now you may wonder, why do PPAs have problems with their language, and why Alzheimer's patients often complain of memory problems? And on the other hand, patients with Parkinson's disease often have motor problems or problems with their movement. To answer this question, we may need to go back a little bit and understand how the brain is structured and organized. The brain is basically comprised of many different groups of neurons that are assigned different functions and tasks in our brain. So what happens in Alzheimer's disease is that the group of neurons that are responsible for creating new memories and retaining them are affected, resulting in impairment in memory. And in the same way, patients with PPA have loss of neurons that are responsible for language functions, hence the impairment in language. In this next slide here, I'd like to talk more into details about the functions of language. The functions can simply be categorized into language expression and language comprehension. Language comprehension is measured on this graph on the y-axis, and the function of language expression here is measured by fluency and grammar on the x-axis. In the middle are the subtypes of PPA. So let's see how each one do with regards to the performance on language comprehension and their speech and grammar. The first one on the left upper corner is the non-fluent PPA. As you can see, it is quite high up on the language comprehension performance, but quite low on the fluency and grammar, which means that the non-fluent PPA generally do not have problems understanding words or sentences, but they do struggle with their speech and grammar. While on the other hand, the semantic PPA on the right lower corner here generally speaks quite fluently and doesn't have any problem with their grammar, but they do struggle with their words and understanding of sentences. The logopenic PPAs is somewhere in between, so they fare generally a little better than semantic PPA in the comprehension and a little better than the non-fluent PPA in their speech and grammar. The question you might have now is then, what caused these differences in the subtypes of PPA? This slide might be able to answer that question. For many years, scientists have known that there are these structures called abnormal protein in the brain of people diagnosed with dementia and neurodegenerative diseases. And these abnormal proteins cause dysfunction of certain groups of neurons in the brain and ultimately causing them to die. The main categories of abnormal proteins that can be found in PPAs include the amyloid protein, the tau proteins, and the TDP proteins. Now let's see how these proteins relate to each subtype of the PPA and how they relate to the presentation of each subtype. The first pie chart here under LV PPA or logopenic variant PPA Even though there are many colors in the chart, you can see that the majority of them is colored in blue, which represents the amyloid beta protein. It's an abnormal amyloid protein. And an abnormal amyloid protein is also a hallmark of Alzheimer's disease. So studies have shown that some logopenic variant PPAs do develop symptoms similar to patients with Alzheimer's disease, meaning that they may develop memory problems later on in the course of their disease. And on to the next one, the non-fluent variant PPA. And you can see here that the majority is colored in dark green, light green, and yellow. These three are all abnormal tau proteins. And there's a small bit of orange here as well. It's the TDPA protein. The abnormal tau proteins here are also found in patients with atypical Parkinson's disease. So studies have also shown that some non-fluent variant PPA do develop symptoms similar to those with atypical Parkinson's disease. And in the same way, patients with semantic variant PPA here has the majority of them colored in red, which is the TDPC proteins, meaning the majority of semantic variant patient has an underlying abnormal TDPC protein. These proteins can also be found in some types of behavioral variant frontotemporal dementia. So some semantic variant PPA may also develop behavioral symptoms similar to those that occur in behavioral variant frontotemporal dementia. Due to limited time today, I'd like to focus on the motor symptoms. So what are motor symptoms? Motor symptoms constitute anything that has to do with the movement and the strength of the muscles. So the first one, Parkinsonism, is the one we see most common in PPA. Parkinsonism simply means any symptoms that are also seen in patients with Parkinson's disease, and we'll go into the details in a little bit. Some patients may develop abnormal movements such as tremor, muscle jerkings, and abnormal contractions of muscles. Bulbar symptoms may present with difficulty swallowing and choking, and some may have difficulty with their speech as well. Eye movement problems may present with double vision or difficulty navigating their eyes in certain directions. Motor neuron disease can cause a decrease in the strength and wasting of certain muscle groups, but they are the rarest one and we rarely see them in PPA. So let's talk a bit more about Parkinsonism. So the cartoon on the right here illustrates a picture of a patient with typical Parkinson's disease. They are often recognized by the trembling in their hands or their head. Their trunk muscles and their limb muscles might be rigid. And when they stand up, they tend to tilt forward a little bit. And when they walk with a short shuffling step and with a reduced arm swing. However, Parkinsonism in PPA is slightly different in its presentation and its underlying cause. So the most common symptom we see for Parkinsonism in PPA is slowness of movement, or the medical term is bradykinesia. Gait and balance problem may occur in PPA as well. Some may develop rigidity, but tremor is relatively rare in PPA compared to patients with Parkinson's disease. Slowness of movement or bradykinesia. The slowness of movement involves slowness in the initiation and the speed of the movement, which means that patients may take longer to do things. They also have reduction of spontaneous movement. Some may observe a reduction in their arm swing, and this reduction also involves their facial muscles, so they tend to express emotion less or have less facial expression. This also affects their control of the hands, so some people might have trouble producing a signature or would notice a change in their handwriting. Doctors often test for this by having a patient do quick repetitive movements such as opening and closing their hands. Rigidity may present with tightness in the trunks and limbs. They may be symmetrical or they may affect one part of the body more than the other. They may experience aches or pains in the muscles or joints that are affected. These symptoms can cause difficulty with changing their posture, such as difficulty turning in bed or getting out of a chair. The problem with gait and balance is, in my opinion, the most important one. Because if a patient starts to have problem with their gait and balance, that means they are at a high risk of falling. When they fall, that means a significant reduction in their quality of life and even their prognosis. So how can we spot this? Patients with this problem may have a flexed posture similar to those that we see in Parkinson's disease. Their imbalance might be easier to spot when they navigate uneven terrains or when they are on the stairs. Their speed of walking is noticeably slower, and they may even freeze in the middle of the walk, which is called freezing of gait. If you have spotted this, or if you suspect that the patient might have some balance problem, please tell your doctor so the problem can be most appropriately addressed. Regarding the treatment of motor and movement symptoms in PPA, as we discussed earlier, that Parkinsonism in PPA is a little bit different from Parkinson's disease in its presentation and its underlying cause. That's why the main treatment for Parkinson's disease, which is levodopa, does not work as well for PPA. Physical rehabilitation has been a useful treatment, and preventative measures such as installing rail in the house, or limit the use of stairs, or simply using a walking gait are helpful as well. In summary, these motor symptoms are not common in PPA and not everyone will have it. The main determinant would be the subtype of the PPA and the underlying abnormal proteins that each person has. The key point is then to be aware that these symptoms may arise and be observant. And should you have any suspicion that any of these symptoms arises, please let your doctors know and we can then assess and address them appropriately. So thank you so much for your attention, and I'm very happy to take any questions in the later Q&A sessions. Thank you.
Many thanks to Anthipa, and so I'm sure there will be some questions for a bit later. We'll try and pick those up. Now I think what we'll do without too much delay is move on to our next speaker. Very, very pleased to welcome the perspective of therapy in Nicola Lauchlan, who is the clinical lead physiotherapist for community elderly mental health in NHS Ayrshire and Arran, and has particular interest in falls mobility problems in older people and in neurodegenerative disease. So we'll hand over now with great pleasure to Nicola.
Hi everyone, my name's Nicola Lauchlan. I'm a clinical lead physiotherapist working in a community mental health team in NHS Ayrshire and Arran. It's lovely to see so many of you here today. I know I've pre-recorded this presentation, so my colleague Claire will be around for any questions or queries that you have about it, but hopefully we'll be able to answer a few of your questions about falls prevention and management in primary progressive aphasia. The first thing to mention is that falls are not a normal part of aging, or indeed a normal part of having a diagnosis of dementia. And if you experience any of these issues, it's important that you speak to your general practitioner or hospital consultant about them. So if you suffer from dizziness, if you black out or lose consciousness when you've fallen, or if you suddenly have an increase in the frequency of falls that you're having, it's important for you to speak to a medical practitioner and get a medical assessment. There are lots of things that can contribute to having an increased risk of falls, and they're not all necessarily related to this sort of diagnosis. So you can have things like poor eyesight, poor footwear, problems with your feet. Unfortunately, being a woman can increase your risk of falling. Aging can increase your risk of falling. So we know that 1 in 3 people aged over 65 fall every year in the UK, and that increases to 1 in 2 people aged over 80. Obviously, having issues with your balance can contribute to an increased falls risk. Having poor mobility, Environmental problems like having rugs and other obstacles around the house, which can lead to you tripping. There are a variety of medical conditions which can also contribute to falling. So if you've previously maybe had a stroke and you've got a weakness on one side, if you have a condition such as peripheral neuropathy that can cause reduced circulation, increased problems with your nerves telling your muscles what to do, that can lead to an increase in falls risk. And things like medicines which you would take to reduce those medical conditions can also have an increased risk of falls attached to them. Anyone who's on more than 4 medications is at increased risk of falling. If you are on more than 4 medications and you're not sure why you're taking different medicines, or if it's been a while since you've had them reviewed, it's a good idea to make an appointment with either your doctor or the local pharmacist to go through the list of medication with you and identify if there are any medications which maybe you don't need to take anymore. Alcohol obviously has an increased risk of falls attached to it, and that's for anyone of any age really. So it's important to be sensible about your alcohol intake. Poor nutrition can have a massive effect on falls risk. If you're not taking in adequate nutrition, if you're not eating the right things, if you're not taking in enough calories, that can lead to you feeling faint. It can lead to your muscles not having enough energy to function properly. And that can obviously lead to an ongoing risk of increased falls. Dehydration is a really important one. If you are not drinking enough, your body won't function very well. And we know that if you want your body to function well, you need to have at least 2 litres of fluid a day. That can include any kind of fluid, from water to diluting juice to fresh orange or fruit juice. The only thing to remember is that caffeine can actually have a dehydrating effect on your body. So if you like to drink lots of tea and coffee, it's important that you also take in other liquid as well. Bladder and bowel problems can lead to an increase in falls, because if we have issues with our bladder or bowel, we can quite often find ourselves rushing to the toilet, and that can increase your risk of tripping. Poor sleep can also contribute to an increased risk of falls, because you won't be as alert, or your concentration won't be quite so good, and you won't have as much energy either to be able to lift your feet properly when you're walking, so it can quite often lead to clumsiness. And one of the big things that we see, particularly with older people and particularly with those on various different types of medicines, is a drop in your blood pressure when you first stand up. So it's important that if you're having symptoms of dizziness and that sort of thing, that you get that checked out to make sure that your blood pressure medication is at the right level for you. There are some hints and tips later on in this presentation that will help you if you're having difficulty with low blood pressure when you first stand up. So there are some common mobility problems that we are aware of when people have difficulty with neurological problems like dementia or previous stroke or that sort of thing, where the messages don't get from the brain to the feet quite as efficiently as we would want them to. This can lead to things like poor balance, poor muscle strength, like I was saying, a drop in blood pressure when we first stand up. Feet sometimes getting a bit stuck when we're walking, so they just freeze and we can't quite get them unstuck to be able to start again. Shuffling is a very common problem, particularly if we have poor balance, because we're not feeling quite so confident to lift our feet as well as we normally would. We often find that people who aren't feeling as confident with their mobility tend to have quite a curved posture. So they round their shoulders, they look down at the floor or the ground, and it's just because they're trying to watch where their feet are going rather than watching what's round about them. So they tend to get into a sort of flexed posture. And we can also find sometimes that when the messages aren't getting from the brain to the feet quite so well, we get a sort of runaway movement sometimes when it's difficult for your body to stop moving after you've started. So you build up a momentum and it's almost like your body doesn't know quite how to stop. These are the common things that can happen when you have damage to the brain. There are lots of ways that we can solve mobility problems. And as a physio, these are some of the things that I teach people when I'm working with them to try and help them solve these problems and try and help to make life a bit easier and help to reduce falls risk as well. There are lots of different exercises that we can do to challenge our balance, to improve muscle strength, and to make our endurance and our exercise tolerance better too. And there are a couple of links to different exercise programs that I can share with you later on in the presentation. I also have some videos now to share with you, which I think can be quite helpful in seeing how to solve some of these problems that we're talking about. So video number 1 is all about low blood pressure. And you can see in this video that we have Ailey, who has difficulty with blood pressure when she's first standing up. Her blood pressure tends to drop. She becomes a bit dizzy. And then quite often what happens is she falls backwards into her chair, or she tries to move too quickly, and that can lead to a loss of balance and a fall forwards. So rather than rushing to get up out of the chair, what we tell her to do is to march on the spot in the chair for a minute or two before she actually stands up. And the reason for this is because it gets the circulation pumping straight away, and that can actually stop your blood pressure dropping when you first stand out of the chair. The other tip that we give people when they have low blood pressure when they first stand up is just to gently pedal their feet, like you'll see Ailey doing in the video, so that they're just lifting one heel up and then the other before they actually start to move. And again, this just boosts the circulation, boosts the blood pressure, and it also gives you just a minute to collect your thoughts together before you try and move. It gives your body a moment just to get used to the feeling of being up. Video number 2 is about getting started. So you'll see from this video, Rebecca has a bit of difficulty getting up out of the chair. And one of the ways we try and help her with this is to get her, first of all, to move to the edge of the chair. And you can do this just one leg at a time, just left to right, left to right. And then we get her just to gently rock back and forwards in the chair so that she can build up some momentum. Quite often people, when they have a bit of difficulty with messages getting from their brain to their lower body, have a bit of difficulty standing up out of the chair or getting started with their movement. And if we just do that small rock back and forwards, it just helps to initiate the movement and build up a bit of momentum. Sometimes that solves the problem. Video number 3 is about stopping runaway movement. So when I'm talking about runaway movement, this is when someone finds it difficult to stop moving once they've started. And again, you'll see Rebecca in this video. She is starting to move. She's taking very small steps. Her feet are a bit shuffly, and she suddenly finds that the top of her body is a bit top heavy on the bottom. So she finds it difficult to stop. And what you'll see is that I come in at the side of her. I put one hand on her shoulder and the other hand on her lower back, and it stops her moving straight away, but in a really safe way so that she can't fall backwards or forwards. We would only expect someone to step in and do this if they were very fit themselves. So if you have any concerns about your own mobility, please don't try to do this. Please try other techniques like asking someone, reminding someone to stop. Sometimes even just saying the word is enough to just stop them moving, or guide them towards a piece of furniture that they can lean against to just stop safely. Once you've stopped the person moving, give them a moment, let them collect their head together, and then we can move on to a technique which is shown in video number 4, all about restarting movement. The thing with walking is that we need to transfer our weight from left to right in order to free up our feet enough to start walking. If you've stopped someone with that runaway movement, sometimes they can find it difficult to restart again. So one of the techniques that we use is just to put our hands on their hips and gently move them or help them to move from side to side. And then you'll see that their feet can start moving again in a nice gentle way. And you'll see I've demonstrated this in the video with Ailey again. The last tip for helping to solve mobility problems, I've recorded here a video showing Rebecca doing some high stepping. So as I said earlier, sometimes when you're not feeling as confident in your balance, you can get a bit shuffly. You know, your feet stay close to the floor, your steps become smaller, you're just not quite as confident about moving as well as you used to be. High stepping, where you lift the feet up as high as you possibly can and exaggerate the movement, although it looks a bit awkward, this is really just something that you can practice at home. And you can also do it as an exercise, just standing at your kitchen worktop, lifting the knees up as high as you can, so that you're encouraging your brain to remember to lift your feet when you're walking. So this is more of a practice sort of move that you can use, just because the repetition can help to re-establish the pattern between your brain and your feet again. And that can help to reduce the shuffling movement. And as a result, it can also help to reduce the risk of falls. There are two really nice exercise programs which are published on the Alzheimer's Scotland website for anyone who's interested in these, and they're really good for anyone. So the first one that you'll see here is a group of exercises for strength and flexibility. These won't do much for your balance because you're actually sitting down to do them. But if you have difficulty standing, if you're not sure about your balance, if you're feeling really lacking in confidence and you really just want something to try and help to strengthen you up and then improve your flexibility, this is a really nice program to follow. The other option is a standing option. So these are 6 lovely exercises that you can do to help improve your strength and your balance. So we've talked about falls prevention and falls awareness and some of the risks that are associated with increased falls. It can be really tempting when you're helping to look after someone who has difficulty with their mobility for whatever reason, to want to wrap them in cotton wool, to want to stop them moving around, just to reduce the risk of them having a fall or an injury. As a carer myself, I've done that before, you know, told someone, no, sit down, I'll get that for you, or no, we don't want you getting up and walking around. No, it's not good for you to go outside on your own because, you know, I'm worried about you falling. And that's really important. It's important to help protect the person that you're looking after. But we also need to look at the benefits of encouraging someone to move. If you're asking someone to sit still most of the time, what you'll find is that they'll lose muscle strength, they'll lose confidence, they'll lose balance. So it's quite important to get a bit of balance between reducing the amount of risk that's associated with them getting up and moving around and them getting the benefit of getting up and moving around as well. This is one of the models that we use as allied health professionals to help us sort of balance out the risks with the benefits of encouraging someone to be mobile. So you can see there are different ways to think about, you know, risk enablement, management, planning, that sort of thing. And this is quite a nice diagram to use to decide what the person is able to do for themselves, what they would normally do, what their motivation is for doing something, and helping to promote their own independence with that. Remember that not all risks can be managed or mitigated, but some can be predicted. For example, if someone's a bit unsteady on their feet, they could have a physiotherapy assessment to maybe provide them with a walking aid. And that can help to reduce their risk of falling because it helps with their balance. And all of the things that I've talked about today, you can get advice about them from your general practitioner, from physio, from OT. My best advice to you would be to speak to your general practitioner and find out how to make referrals to these people if you are having difficulty with falls. If you have a community health practitioner involved in your care, like a community psychiatric nurse or mental health nurse, they generally will be able to refer you to a physiotherapist or an occupational therapist, or the appropriate person to get assistance with the kind of falls risks that we've talked about. Please don't suffer alone. If you're having difficulty with these things, all of the professionals that are in your area are there to help you deal with that. That's what we're all here for.
So thank you so much, Nicola. That was really fantastic practical insights and tricks for managing a lot of these problems. And I certainly learned a lot from that myself. So I hope that was useful. Those links and resources that Nicola's mentioned, as we said at the beginning, we'll circulate those and make them available. So don't feel you need to copy all those down in real time. So now it's really over to you. So this is the segment of the PPA support group that's always particularly resonant, I think, because we get members of the support group to come and chat about lived experience. And today, very, very pleased to welcome Audrey and Will Barclay, and they're in conversation with Anna Volkmer. So we'll hand over to them now.
So hello, welcome. Thank you everybody for coming to the PPA support group today. Today I have with me Will and Audrey, who have agreed very kindly to talk with me today and share their experiences. Now, Audrey has a diagnosis of progressive non-fluent aphasia, or PNFA, and I thought we could have a bit of a chat about that today. So firstly, perhaps, Will, could you tell me a little bit about how and when you both noticed Audrey's first symptoms?
Probably in 2016, but when we were on a family holiday in 2017, we noticed a lack of engagement, but we thought this was more Audrey's reluctance to travel and the heat. We hit Greece at the hottest time we could possibly have done. Also, I thought maybe because I was around more, this impacted her lifestyle. But it took a friend in 2017 who hadn't seen her for a year to ask if everything was all right, because we went out to dinner with them when they stayed with us. Yeah. And they noticed Audrey's lack of engagement. A while to get her to go to the doctor, though. She was very reluctant to do this. But when she went with my daughter, the doctor ruled out depression. Right. And referred to the local memory clinic, which we went to in mid to late 2018. Well, it's helpful that they ruled out depression, but I know, Audrey, you were first diagnosed with a PPA, weren't you? But it wasn't progressive non-fluent PPA, was it, that you were diagnosed with? Can you tell me a little bit about that and how that happened?
No.
It was LPA, logopenic progressive aphasia.
Yes.
The doctor did say that, he did caveat it by saying that all of these rare dementias were not straightforward. And I think everybody who's suffering from this will know that. It was after our first examination with Professor Warren's team in November 2020 that he said to us he was fairly certain it wasn't LPA, it was PNFA. And that was confirmed when all the data came together. Yeah. And then it was confirmed. Yeah, but with PSP and CBD, I don't know what you would call it, links, undertones, symptoms, particularly the PSP, because talking to someone who has a partner with PSP, I can see the similarities. That makes sense. So you've got non-fluent, or you've got progressive non-fluent progressive aphasia, you've got PSP or progressive supranuclear palsy for those listening, and you've got CBD or corticobasal syndrome as well for other people listening, or tones or undertones. Now, Audrey, you were a dance teacher, weren't you?
I taught line dancing.
Amazing.
I had to give it up because I couldn't do the steps.
Okay.
Yes, she first stopped giving verbal instructions.
Yeah.
About October or November 2019. And then when lockdown came in March 2020, obviously all the classes were suspended.
Yes.
Thinking lockdown would finish, she started to practice again, but she could not keep up with the music. But up until March 2020, she was still choreographing dances.
Wow.
So at that point, she was still being able to put a dance together. But when she practiced, it was probably about 5 months after lockdown, she said, I can't do it. And I don't think it was lack of, I mean, I think if she'd have carried on practicing, it wouldn't have made any difference, because we know more now.
As you've kind of known more, has walking also been something that's you've noticed becoming tricky since then?
No, I have trouble going down the stairs.
Mm.
And up the stairs.
Yeah.
But her gait is slower and more open. So that's almost like a balancing, you're trying to compensate.
Yeah.
She's also unsteady over undulating surfaces. I can hear her foot scuff because she hasn't lifted it quite enough. It's only fractions. And if she turns or stops suddenly, she could fall backwards or sideways. And there's no warning, is there? It's not dizziness or lightheadedness, nothing like that at all, because I ask her that every time. In the last week, she's fallen twice when she's gone to sit down, where she's thought the chair was behind her and it's been a foot or two away. You know, if we go to a restaurant or go out for a coffee or something, I will always hold the chair for her and make sure she gets in, because we're in a strange place.
Mm.
But, she does have trouble pulling the chair up behind her, so she's sitting quite away from the table, so we have to develop strategies to get her to sit down and stand up. I always tell her to put her hands on flat on the table and lift herself up that way.
I know that we've often talked about curbs, haven't we, in our conversations in the past, and getting up and down the curbs. And I wondered how you manage that.
With difficulty.
Mm.
And the other thing is in shops, because Audrey was a professional shopper, and professionally in inverted commas.
A woman after my own heart.
She's reluctant to go into shops now, especially with me. I think she's going in with some friends in a few weeks, and our daughters. But also one's conscious of gondolas at the end of aisles, racks of clothes, display boxes and stuff like that. And of course, other people won't be aware. I mean, if she was carrying a white stick, it might be different, but people dashing from here or there. So if she suddenly moved out the way, she could easily go, because it's intuitive to do that if you see someone rushing towards you.
I know that you've often talked about when you go out that Will, you and Audrey have held, or you've held Audrey's arm or hand, and you've often worried about it more than Audrey has. And I was wondering perhaps whether it's trickier sometimes for you or for Audrey.
Well, yeah, in some ways she's a bit oblivious to it. When you get to our age in 73, you've done the same thing all your life. So when she tries to stand up sometimes, she'll try and pick something up and stand up with it. But she's always done that.
Yeah, of course.
And getting that out of your routine is very difficult. She does sit on a chair now when she's getting dressed. For most of the time she's getting dressed, and we've got some special chairs that we put in the shower rooms.
I know you mentioned that Audrey had missed the chairs this week. Has Audrey fallen any other times?
Well, the worst fall was Well, this is another thing. Everybody who's dealing with PNFA is a yes, no.
Indeed.
What she because she has fallen.
Yeah.
Worst fall was when she fell backwards when halfway up the stairs last summer.
Yes.
And she thinks she missed her footing. Luckily, she was only stunned and bruised herself. We got a small landing, 2 steps up, and then the stairs go up at a right angle here at home. So she landed on that small landing and then rolled onto the hall floor, which is all wood. Several times since then, she's either fallen off a chair or just fallen over getting dressed. Although now she does, to be fair, she's not done that recently because she always sits down when she gets dressed.
That's handy. And that's a really good tip, isn't it? I know that you've thought of lots of other ways of modifying your home. And I wondered if you could share those with us, Will.
Yeah. Well, I did speak to an OT, occupational therapist. That was earlier this year. That was after coming to UCL. Professor Warren recommended that. But the OT felt that all the measures that were in place or were pending were good enough, with the possible exception of a stair lift. Well, Audrey doesn't want to have a stair lift at this moment. And I think has to be a balance between independence and safety. And at the moment, because we've got the extra banister and she is fully aware of the danger of the stairs, I feel relatively comfortable in that area. Funnily enough, it's more other areas because she doesn't carry things upstairs with her now. So I mentioned already we've got chairs in all the shower rooms and bathroom. These are chairs that we got from a healthcare shop.
Yeah. What about the lights? You've told me about the lights in the night, and I think that's a wonderful idea.
We've got a dark passageway, darkish, that you don't think about until you have something like this. So our electrician fitted a motion sensor light that's wired into the mains. And in our cottage in Dorset, we've got battery operated motion sensor lights, which you can get off Amazon. You get a pack of about 6 or 7, and they're good for traveling if you go away, stay away somewhere, and they really work well. Yeah. As soon as they pick up a movement, they're on. Even if the gap in the door is 1/4 of an inch.
Wow.
On the Dorset cottage, it's got a very small landing, and we use a child stair gate at the top of the stairs there. Right. So that with the light, there's not much more we can do. Right. And then we've got grab rails in the showers. Yeah. They're the suction ones at the moment. We're in the process of thinking of getting our bathroom and our shower room, the shower room here modified, make it more accessible for Audrey. Sounds good.
So a combination of the advice from the occupational therapist and these kind of genius ideas that you found through Amazon. I guess that the stair gates, I know that stair gates can be helpful, but can also pose a risk for some people. So I suspect that that's a decision people might need to take more carefully. But there's...
I always take it down every morning.
Yeah.
Because otherwise you step over it.
Yeah.
Step over the... It means you got to put it up every night, take it down every morning. But anyway, that's what we do.
And I guess if you were to recommend to other people, would you recommend that they get an occupational therapy assessment, or do you have any other tips or hints that you would recommend for people?
Well, it can't do any harm because each is different.
I think that's a really nice summary, because even though somebody might have the same diagnosis as you, Audrey, they might be very different or have a different home or have a different issue going on at that time. And I think that's a really valuable point, Will. Everybody's different.
Yeah. Yes. But the simple common sense things can all be done anyway by yourself. You don't have to do what we've done and have the light wired into the mains. The battery operated ones work perfectly well.
Brilliant. Yeah, that's a wonderful tip, and the fact that you can just buy them off Amazon, I think that's handy for everybody. Now we've been chatting for a little while now, and I'm mindful of the time, so I'm just gonna bring our meeting to a close and mention that Will and Audrey, but particularly will be available for the Q&A this morning, as will I. Thank you everybody for listening, and thank you ever so much for Will and Audrey sharing your experiences. It's been so valuable. Really appreciate it. Thank you very much.
Thank you. And thank you for all the help you've given.
Thank you.
So some fantastic tips. Thank you so much to both Audrey and Will, and to Anna for facilitating that. Particularly like the excuse me, the point about you listening to sounds of people's walking changing. Something I try and tell the junior docs actually. So Will's already mastered that well and truly, and also this idea that the world sometimes seems to be arranged as an obstacle course for people with neurological diseases of all kinds, which is quite telling, I think. And the Vicar of Dibley phenomenon we may come back to later on in the Q&A, which is something that we again trying to educate GPs and doctors about, so that they recognise this for what it is. I've got a brief advert for some research, and this is for Ali Rose Sisk, who's a PhD student between the Institute of Neurology and the Division of Psychiatry at UCL. Ali Rose is a clinical nurse originally, who's pursued an academic pathway doing a PhD, particularly focusing on symptom management, palliative management of people with frontotemporal dementias, including PPA, and management particularly of the very important issue of pain. So there's a very short video which is just making a plea for people to may want to be interested to talk to her about her research and be involved in that research. So I'll hand over to that video now for Ali Rose.
Hi everyone, my name is Ali Rose Sisk, and I'm a second year PhD student at UCL, University College London, and I'm also a staff nurse here in the UK with a huge interest in all things dementia care and palliative care. So my PhD here at UCL is all about exploring the palliative care needs of people with frontotemporal dementia, or FTD. And as part of my PhD project, I'm going to be looking at better understanding the physical, psychological, social and spiritual needs of people living with moderate to severe stages FTD. And this is all to contribute to developing better and best care for people living with FTD. So as part of my research, I will be collecting information around physical, psychological, social and spiritual symptoms from people with FTD or their carers. And I'll be collecting this data at baseline, so when I meet you initially, and then every 3 months for 9 months. So there'll be 4 data collection points. So who am I looking to speak to at this time? Well, I'm looking to speak to RDS members with lived experience of late stage or moderate to late stage FTD. So this is likely to be perhaps family carers, relatives, friends of those with FTD. And I'm looking to speak to you. The data collection points will last about an hour and can run online. Of course, now with COVID and all that, the data collection can happen online or perhaps in a room at UCL. And I'm going to be meeting you to conduct these interviews. But the overall study is led by Professor Liz Sampson, who's a consultant psychiatrist here, and she's at UCL. So if you're interested, you think you might know someone that's interested, or perhaps you've more questions for me, then you can contact me directly on my email, which is just at the bottom, or even my phone, which is also here at the bottom. I'd be very happy to answer any questions at all around the study. And I suppose I'd be looking to recruit 25 to 30 people to this study. And the more people we have, the more information we can collect on the experiences of those with FTD, and the better care, of course, we can provide, which is the overarching aim of this type of work. So I really look forward to hearing from you all, and thank you so much for listening today.
So very important research. Just to say that we'll, as always, with these other things we're talking about, we'll make those contact details for Ali Rose available later if people are interested in being involved in the research. Can I just make take a very brief time before we go to the panel discussion to make a couple of plugs, and just to make sure people are aware of things. We're really getting a lot of very positive feedback now about the role of small satellite groups and buddies in PPA and in other forms of rare dementia. That's something that we're really trying very hard to promote and to get more people involved with. So interested to get your thoughts and feedback about the role of the small spin-off groups and buddies. One sort of standing item is we sort of trying to get people to kind of, again, in the spirit of involvement in the group, if possible, to do the signing up to it well in advance of these webinars, because otherwise what tends to happen is that there's a flurry of last-minute requests to be sent links and things, and we're trying to sign people up. So Nikki and her team and Alicia, who have worked tirelessly setting all of this up and are working behind the scenes even as I speak, are very keen to get people signed up and so they can get you sent out the various details in advance. And so certainly people that come in through our clinic, we routinely, what I hope, ask people with PPA tell them about this and ask them and send a link to them. But it's good to get that done. And then you can also get the newsletters and other things, of course, as well, and be involved in other things. And a bit of an advance notice for next year. It won't quite be, well, it'll be the new normal, the new post-COVID normal, won't quite be the old way. But what we're planning to do for next year is have 3 of these meetings, of which 2 will be webinars and 1 will be live in London. We'll get Nikki's to her team to circulate the dates and things to you, but just to flag up that we'll kind of have a hybrid situation for next year for the PPA support group. I think it's time to hand over to another very popular sort of standing agenda item, which is the panel discussion, Q&A. And what I'll do is I'll hand over to the panel chair, who for this meeting will be Anna, who will take things from here. So Anna.
Thank you, Professor Warren, very much. And thank you to everybody for all the videos. They were so interesting. And I myself also learned so much. So I'm going to welcome and invite everybody who's on the panel for the Q&A to turn on their videos and their microphones. And I'm just going to let the audience know that I have a list of questions that people have submitted prior to today and also during the meeting. And I will gradually go through that list in the order we've received those questions and see if I can't find the right person to answer some of those questions. So the first question actually perhaps is a nice question for Professor Warren. So this is somebody who has commented on the fact that their husband is permanently cold and he wears a jumper all through the summer. And this person was asking if that is common for people with PPA.
Yeah, no, it's a very good question. And in fact, changes in awareness of temperature and also actually awareness of pain and other more automatic forms of touch signal are very common. It does depend a little bit what variety of PPA, and in fact, the FTD, the sort of wider group of the frontotemporal dementias that you have, but it can be an issue. I mean, what we normally say practically is we make sure that there's nothing that can be, it's not signaling something that should be treated. And so for example, with that particular symptom, we usually recommend that someone had their thyroid function checked, because the most common medical reason for feeling cold perpetually or having changes in temperature perception is obviously not PPA, it's thyroid problems, which are treatable. So that would be the sort of order of business. But if it is, it may well be due to the disease. And really, there's no specific treatment needed for that. It's more, one, it might signal someone needs a bit more watching from the point of view of their autonomic nervous system, because one thing that can sometimes go with that is changes in things like blood pressure, and that can be of course a very important issue, which comes back to the theme that Nicola and others were talking about of the falls. But also just thinking about practical strategies and not, often not making too big a deal about it. If someone wants to wear an extra jumper, I mean, that's fine. It doesn't really matter if they're not, necessarily in line with what everyone else is doing around them. Obviously, unless they're overheating. Sometimes people can get very fixated on particular clothing, and that can be an issue if they're in the middle of a crowded tube carriage, for example, and everyone's getting very hot and bothered. But in general, we try simple strategies, not usually medicines, but kind of simple strategies. But yes, it can be quite a common, and it's also very under-recognized by doctors that people can get these changes.
Okay. Thank you, Professor Warren. That's really helpful. Now, I'm going to ask a question. I think this is probably one for Nicola, but perhaps Anthipa and Professor Warren might like to add something. So this is somebody who's talking about their father, and they comment on their father's mobility becoming weaker and less stable, with one recent test showing that the nerves in his feet are not functioning. And the person who's asked this question has just asked about whether these behaviours or problems are something that might be to do with a PPA or a dementia, or something else they should worry about, Nicola.
Thanks, Anna. I think, a bit like Professor Warren has just said, it's important to establish the reason for any sort of change in nerve conduction, and sometimes these issues are related to PPA or other types of brain issue, but sometimes again they can be related to thyroid issues, they can be related to diabetes, circulatory problems. There are lots of different reasons why those issues may be arising with the feet. So it's important to figure out why those are happening so that the best treatment can be initiated for them. But it's also important, if even once the reason is established, that the feet are really well looked after, because quite often people with nerve issues in their feet won't realise if they have damage to their feet, so it's important to make sure you're wearing good footwear, good socks, seeing a chiropodist or a podiatrist if you do have any issues with the feet, and just really looking after them properly to prevent any issues with falls or that sort of thing. It's a tricky one because we don't always know if problems like that are related to the dementia that someone has, or and if they have peripheral neuropathy and things like that, which is a condition that's caused by diabetes or circulatory issues, there's no real kind of treatment for that. So it's just a case of trying to keep someone as active as you can, and, as I say, looking after their feet well.
Thank you. And Anthipa and Professor Warren, would you like to add anything to that?
Right, so largely I agree with Nicola's assessment, but I think the bright side here is that we know that if the gait problem or balance problem is due to degenerative diseases such as PPA, then there's nothing much you can do except preventative measures. But if it's due to conditions like peripheral neuropathy, then some causes might be reversible or treatable. So that's worth exploring as well.
Okay.
Yes. Yeah,
and actually peripheral neuropathy is a very good example of something that is very rarely, if ever, due to PPA as such. And so if someone says truly does have peripheral nerve damage, so having changes in sensation in the feet is much more non-specific. But if you get to the point that somebody suggests peripheral neuropathy, and sometimes physios may, and other allied health professionals may be the people that suggest this, don't let the GP say that's the PPA because it's those sorts of, it depends what it is. So some types of problems are quite likely to be PPA, or very likely to be. Others, we're not sure. But peripheral neuropathy is very unlikely to be PPA. It's much more likely to be something like diabetes. So it's important to get all these things checked out and to make sure that you feel you're getting an adequate response. So we're very against, in the wider Dementia Research Centre, but also in the groups, rare dementia support groups, we're very against dementors attitudes, which sort of say that everything goes wrong with someone is just due to their dementia. We don't like that. Okay.
Absolutely, yeah. Even when you've got PPA, other things can come up, can't they? Now there's a question here, Will, that reminds me of a conversation that we had, you and I and Audrey. And I thought maybe we could share you and I could share some of what we talked about. So this question is about a lady's commented on her, I presume somebody commented on their mother and said that their mother with PPA is losing her confidence in going out in social situations. She said that her mum does have fun if they go out, but getting her out of the house is tricky. And she often says no when people suggest going out, or if the dad or her husband suggests going out, and wondered if we had any tips on how to encourage somebody to go out.
We don't actually have that problem.
No.
Something I'm not really, no, I'll rephrase that. If Audrey is comfortable with the people we're meeting, it's not an issue. There was some friends had a golden wedding anniversary just recently, had a boat on the Thames, but there were over 80 people.
Yeah.
And we chose not to go, because it was on a boat, so you got the balance issues. And then you've got all the people that we hadn't seen for years coming up and grilling us. So that was our decision, and we made the right decision because it hammered rain all day. So everybody was confined inside. So that was the only issue we've had. And we talked about it a lot, about shall we, shan't we? But when we're meeting family or close friends, that's not really been an issue so far.
And I remember in our conversation, we talked about meeting people in smaller groups.
Yeah.
And actually that when meeting people in smaller groups, it's much easier to communicate, whereas the larger a group gets, the harder it can get to communicate.
Yeah. And Audrey's quite happy sitting listening. She met some old colleagues of hers recently. And I said, did you say much? And she said no, which was what I expected. But she enjoyed herself just the same. So
yeah. And I know that you both you often kind of schedule things in advance and pop them in the diary so they're there, rather than springing things up all of a sudden.
Yeah.
Which I think is really neat as well. Thank you, Will. Thank you for that. So there's a couple of questions here that I just want to tackle because they're right at the beginning of the list, and they are going back to the sessions that we had held last time. So the last support group, we invited Alison, a dietitian, to speak to us. And a couple of people have asked questions that are relevant to what Alison spoke about. And I would direct anybody who wants to talk about nutrition or diet to those videos. But specifically, there's a question here. Someone said they've noticed that their husband has difficulties controlling the amount of food he eats and picks up the next sandwich before he's finished the previous one and starts on it while chewing the first. And the person asked, is this common in PPA and what can we do to manage it? And so Alison talked through a number of management strategies in her last talk, and we can include the link to the last talk near this talk. But that's something I often get asked too. And Alison and I have often made the same recommendations, as I often work with dietitians, speech and language therapists and dietitians work together a lot. And both of us would say this is often to do with somebody who is having trouble managing their impulses maybe, or judging how much food to put in their mouth perhaps. And this is not uncommon when somebody has semantic variant PPA. We see that a lot, or particularly in that group. But I do see that sometimes when somebody has non-fluent PPA, and sometimes when somebody has a logopenic PPA, it's more about the sequencing of tasks that we have the tricky issue with. So when they're trying to sequence their meal plan. But I often suggest giving people their meals in smaller amounts. So you might create a smaller meal and with over a series of sources. So you're kind of supporting them to judge how much they put in their mouth in smaller amounts, or using a teaspoon rather than a full knife and fork or full dessert spoon. So having a teaspoon automatically means you put a smaller amount of food in your mouth. And using verbal prompts, so perhaps telling somebody to slow down. Some clients I've worked with have even themselves decided, rather than a verbal prompt, having a written prompt on the table. But I recommend going back to that, or asking your GP for a referral to a speech therapist and or a dietitian if that's something you want to talk about. And I just want to comment in line with this. Somebody's also asked about diabetes, and they've asked about that their relative with PPA who is diabetic can't remember when they've eaten, and you have to lock food away as their blood sugar goes very high and he's always hungry. Again, I would recommend actually you go and see make sure that you get advice from a specialist diabetic nurse, but equally go and see a dietitian, ask for advice from a dietitian via your GP. But yes, I think, again, this probably related to similar things to do with judgment and impulsivity, but also to do with we sometimes see people becoming very fixated on foods, and so they go and they're trying to have more of and eat lots of one food. I recently had a client, and if she had a bag of oranges, she said she'd just eat the entire bag of oranges, for example. It's not necessarily always sweet foods. So sometimes we do suggest to people that you move foods, you make certain foods less available than others. And you might need to support people to manage that routine in that way, by putting, and some people have chosen to put locks on cupboards or fridges, or move foods out of reach. And I can see Professor Warren nodding vigorously. Does anybody else wish to add anything to that comment I've made?
I would just add, thank you, Anna, just to say that this is an issue particularly for somatic dementia patients, people living with somatic dementia, excuse me, people with non-fluent aphasia quite often develop, as it goes along, problems with more physical aspects of swallowing and chewing and eating, but the problems with sort of behavioural changes around food, that can be either wanting to eat all the food there, eating too quickly, or changes in the type of food, often sweet tooth, but as Anna rightly says, sometimes the opposite, or very narrow preferences where one person wants to eat only one particular thing, and sometimes quite unusual preferences, which are probably to do with the loss of understanding of food and what conventionally goes with what in the culture, or what's norm for your culture. And obviously the world's cultures, we all eat all kinds of different things, but it's whether you're wanting to eat things that are different to what your sort of normative culture, of which the dominant one, of course, for us is the sort of Western British food preferences. But those sometimes do need sometimes need medication to try and help if it becomes a really significant problem. But usually the mainstay, as Anna says, is around management of kind of the type of food that someone has access to, and sometimes even controlling access, as you rightly say.
Thank you, Professor Warren. I'm just noting that some of the questions are being answered in the chat boxes, so do keep an eye on those. So just as an example, somebody asked a question about falling backwards, as in terms of in the light of their frontotemporal dementia diagnosis, and asked whether that was associated, as the carers at the care home where their father is currently in, their father's currently in respite there, and they say he's got a tendency to fall backwards even though he's mobilising with a frame and supervision. And Nicola, you answered in the chat box, yes, it is. If he doesn't have a physio assessment, this is recommended, though having a walking aid adjusted down slightly can help encourage someone to lean forward a bit more and discourage leaning backwards. And you suggested asking the care home to refer him for a physio assessment. Did you want to add anything more there, Nicola, for any of our listeners?
No, I'm just conscious of the fact that there's quite a lot of questions coming through, so I just wanted to add some typed ones in case anyone's sitting waiting. But yeah, when someone is falling backwards, it's quite a common issue that I see with different types of dementia, actually. And sometimes adjusting their walking frame down a couple of notches just helps them to lean forward into the frame rather than sort of standing right upright. So it's their instinct as physios to adjust a frame appropriately to allow someone to stand, taller. But actually, when you've got someone who's falling backwards, it's better to encourage them to lean over their Zimmer frame. So yeah, just in case anyone is struggling with that, it might be an idea to kind of think about that and ask a physio to have a look at them again if they're having difficulty.
Thank you. It's so fantastic having you here, Nicola. Thank you. And you're right, we do have quite a lot of questions coming through, and what we'll do, if necessary, if we can't get through them all, which we often don't, is we send the questions round to the panel after the meeting, and our panel will write a response and we'll pop that onto the website so that attendees have access to them. I've actually got a question here now that I think might be appropriate for Trish. So somebody's been asking about their loved one. So this lady's husband has PPA, logopenic variant PPA. He attends a dementia daycare centre and he's been about 6 times, and he says he doesn't want to go there. He's feeling bored, and he finds it difficult to give reasons about why he feels bored. But this person's insisting on him going there because they believe that this person needs the social interaction, as otherwise there's only the 2 of them. And the people at the centre say he's fine when he's there. And the person who's asking this question is asking whether they're doing the right thing in insisting that he goes. What do you think, Trish?
Yeah, I think that's really interesting. I think a lot of people who are concerned about how they're going to cope in a situation will say no to something. No is a kind of instinct of protection, maybe. And I understand that. Maybe the noise levels feel a bit stressful and not quite sure they're going to manage. They might feel a bit tired, might not want to go through the journey and kind of wish they could just arrive, but maybe don't like having to walk to a car or a bus. And they might be quite stressed at how they're going to get there. So I think it's true that we have to accept that sometimes somebody going to a day service isn't necessarily because it's absolutely best for them. I think we have to accept that sometimes it's because the carer at home needs the time. And we have to recognise that sometimes the carer has to have some breaks, and that's the best way and safest way of doing that. And I recognise as well that without a doubt, it feels terrible to send somebody off to something that they're saying they don't want to go to. But I think the conversation is to be having with the day centre staff, what is he like when he's there? And maybe they could even send you or show you a couple of photos to put your mind at rest, that he's fine, he seems quite happy, he's joining in or whatever, and his expression is that he's quite calm, might make the carer feel a bit or less upset. The truth is sometimes as a carer, you have to put yourself first a bit. And that's important, because if you're struggling, then you're not going to be able to care tomorrow for the person that you love. So you have to sometimes think, well, at the moment, I need you to go because I need just to sit and do nothing, or I need to go and meet a friend, or I need to get some shopping or do some stuff. So I think it is about working out the bigger picture and being a helicopter on this and saying, okay, he doesn't always agree on going. That feels a little bit horrid that I'm asking him to go, but I have checked that when he's there, he's having a good time. He seems to be okay. It's a safe place for him to go. And for me, it's a really important break. So I think you just have to ask a lot of questions around that subject. And that might feel, that's a really big question, I think.
Can I just throw something? Thank you very much, Trish. Got something into the mix, which is particularly with people with non-fluent PPA. Many of you living with it will know this. You have to be quite careful. This is something that Will was flagging up in the session before, that people say the opposite of what they mean. And obviously actions do speak louder than words, literally, sometimes in this situation. But this saying the reverse. We've absolutely had people who have, for example, initially missed out on signing a research consent because they told the fellow no, and they meant yes, and it can actually have practical implications. So this is the so-called Vicar of Dibley's symptom, which those of us of a certain age will recognise from the television show. But it is a significant problem. It's no joke, and it can extend to other types of words where there are alternatives to, like hot and cold, those sorts of words. And actually, the other thing I just to mention, which again we're sort of more thinking about the whole theme of the meeting, which is the sort of motor and neurological aspects. that symptom, we think, at least in our clinical experience, we need to prove it sort of in research, but our clinical instinct is that symptom, when it occurs early on, can be a harbinger for problems people that are going to go on and get problems with Parkinsonism and falls and balance problems. In other words, the PSP, CBD overlap syndromes that Anthipa was talking about, as can, and Audrey's experience, I think, was very interesting. So that so-called misdiagnosis of logopenic aphasia, what that might actually be is a problem with producing speech. So people who are on the track to get PSP type Parkinsonism quite early on lose the ability often to make small talk, to initiate conversation in the normal gambit that we all take for granted. And this can show up as a long pause in the conversation. And neurologists are taught that long pauses are a hallmark of logopenic PPA, which they are, but it depends what sort of pause. So that can also be a warning that someone might be on the track. So there may be ways to anticipate some of these motor and other problems early on, and you need, as I'm sure all of you do all the time, but certainly for carers and practitioners coming into it who haven't had past experience, need to be really very sensitive to what people are saying and how they're saying it early on.
And Will, perhaps you could tell us a bit about the yes and no's and how that affects. Is that difficult for you and Audrey sometimes?
No, I tend to make a bit of a joke of it, except when I'm asking her if the traffic's clear. I've learned not to do that now after one near miss. But Audrey will still say, she will now say it's clear rather than yes or no. I'll say, can I go? Because I tried to carry on involving her, but I'm looking at the same time. So, yeah. But yeah, I wouldn't say it was now. I'm very aware of it, so I analyse whether before I ask the question whether it is a yes or it is a no, and I'll repeat or seek clarification.
And yeah, thank you.
Other people won't realise that, of course.
Exactly.
Right.
And I think
do you want your change? Being half Scottish, I'd naturally say yes, but she might say no. So, sorry about that, Nicola, but you know what I mean.
Yeah. But you've made an excellent point, Will, about the being in the know. And so if the person themselves is in the know, they can take, Audrey has strategies of working around it herself. And you as the communication partner have strategies of working around it. But if the other people don't know, they might not realise. Yeah, absolutely. Thank you, Will, for sharing that.
Okay.
I've got a question for Nicola, I think, or at least something that I think, Nicola, you and I would recommend another colleague to look at too. So there's somebody who's asked about their mum is nonverbal and displaying symptoms of Parkinsonism. So no facial expressions, no handwriting and rigidity. And she's obsessed with going to the toilet, and that's becoming really hard for everybody to manage. So she wants to go every 5 minutes and needs assistance with toileting. And do we have any suggestions to help with it? And I'm actually going to link it to a second question on the same topic, where somebody's asking about suggestions to manage toileting in terms of actually going in and out of the room and sitting down, getting up and down. And I know you will have some suggestions, but equally there's another, so allied health professional therapist in our in the therapy team, who might also, an occupational therapist, I presume, that you or I might work with. Is that fair, Nicola?
Yeah, I think so. But the other thing to mention is, I think with any issues to do with bladder or bowel, similar to what we were talking about before, should be investigated fully before we go down the road of managing those issues. So if those issues have not been investigated fully, if there's no if they haven't been looked at in terms of infections or other problems with the waterworks or with the bowel or that sort of thing, that should all be done before we decide on how to manage those issues. And that can be done through the GP with referral to other consultants if needed. There are nurses as well who specialise in continence issues, who can be really helpful in these situations. Occupational therapy can help with, different aids and adaptations to help manage the actual practical elements of getting to and from the toilet. And there are different medications and things you can take to suppress the urge of actually needing to go to the toilet and things. So there are lots of different aspects to that kind of problem that really need to be managed by a team rather than just one professional. But that should be fielded through the general practitioner generally. And if that's not happening, if you have a mental health professional involved with the person's care, then please speak to them to advocate for you in that regard.
Thank you, Nicola. I think we've got time for one more question, maybe two. We'll see how we get on. So the next question is, I think, for Anthipa, and it's somebody who's asking about their wife who was diagnosed with PPA 4 years ago. And they've recently noticed that her whole body intermittently jolts, and it appears she doesn't actually realise this is happening. Is this something you could comment, either Anthipa or Professor Warren, maybe?
Right, so the jolting involving the whole body. So, yeah, thank you for raising this. So I think this might be something called myoclonus. So myoclonus can involve small muscles like jolting or jerking of the hands, feet, certain body parts, or it can involve the whole body, making it look like the whole body is jolting, and sometimes that may result in falls as well. So yes, that may happen, and it tends to happen in a kind of like a corticobasal phenotype, which might be a little more common in the non-fluent PPA subtypes. But all in all, we need to assess that properly, if it's just the movement like myoclonus jolting, or is it like a mini seizure that we mistaken it for like a jolt. So I would suggest having a proper assessment of that, and whether it's a myoclonus or a seizure, there's some medication that can be given to treat that. Yes.
Thank you.
Yes, and the commonest time we all get this actually is when we're falling asleep and you feel like you're falling. That's a jerk. That's a myoclonic jerk. That's normal. But when it starts to occur at times, of course, when someone's awake, and that could be part of the brain problem. And as Anthipa rightly says, it needs to be take a history of what's going on, and doesn't by itself necessarily automatically need treatment. It depends if it's distressing, if it's interfering, particularly if people are starting to get very frequent jerks that interfere with their nursing care or with their eating or those sorts of things. Sometimes these jerks get more kind of obvious if someone's trying to use a body part to do something like eat. And if it's a warning sign for potential seizures, and sometimes that we know that it can lead into generalized seizures, which of course we do usually try to treat. So there are particular medications, anti-epilepsy medications, that can be used. It's becoming more of a problem like that, but it can occur in any of the PPAs as it gets more severe. Probably more common in logopenic because it's an Alzheimer variant, which happens, but that's more the limb-related jerking or little jerks. The big jerks, as Anthipa says, are less common, but they tend to go more with the corticobasal, which goes more with the non-fluent. So one thing that's come out of this meeting is just how complicated these diseases are neurologically, and how many confusing terms there are. And it is very confusing even for neurologists. That we think we understand how they fit together, but it's actually very difficult, I think, for people coming into this cold to keep track of all these different terms.
Yeah, thank you, Professor Warren. And I think the other thing that's come out of this is also the value of involving lots of different professionals. So not only neurologists, speech therapists, nursing staff with different specialisms, physios, occupational therapists. There's a whole team, a whole raft of specialists who might be able to be useful. and I'm mindful of time, and we still have some unanswered questions. We've done really well, but we do have just a few questions that we haven't answered. So I'm going to suggest that we keep those and we answer them later on after the meeting today. And I'm going to say a last big thank you to everybody. So thank you to Will and Audrey. Thank you ever so much for your time. Thank you to Nicola. Really value your input. Thank you very much. Thank you, Anthipa, and thank you, Trish, and thank you, Professor Warren. And I think we hand over to Professor Warren to do the final farewell, and we'll finish up the Q&A panel from here.
Thank you very much, Anna, and for all your work as well. And we're drawing things to a close now, but I wanted mainly to say thank you to all of you, and you, as usual, are the ones that ultimately make this group, definitely, but you also make our research, because without you, there would be no research in these conditions. And it's always a great pleasure to get to meet you all, and also very courageous of people who are prepared to come forward, be in the group, be in research, and we do greatly value you, all of you that do that. The final thank you, before we draw things to a close, we will send the meeting agenda, and as we've said through the meeting for next time, and the meeting dates for next year. Nikki's team are onto that, and we will send through both the information about resources and things, and also the follow-up to the answers to the unanswered questions, which we will get onto. But the final thank you is there's a brief message from our sponsor, Eva and her team at the National Brain Appeal, who are the ultimate backers of the group and funded and make it possible. So there's a short video talking about their work, but I will say goodbye at that point. Thank you all so much.
Hello, my name is Eva Tate, and I'm the Major Appeals Manager and Manager of the Rare Dementia Support Fund held by the charity the National Brain Appeal. The National Brain Appeal raises money as the dedicated charity for the National Hospital for Neurology and Neurosurgery and UCL Queen Square Institute of Neurology. The National Brain Appeal raises funds for Rare Dementia Support's 2,000 members to help individuals living with rare and early onset forms of dementia, their families, friends, and healthcare professionals. And we also hold several other funds for FTD and dementia research. The funding helps not only the support group meetings in London, but also the regional support groups, admin and support staff, and all other associated expenses, including the new online support groups. When things return to normal, there are travel and accommodation bursaries available to help members attend the meetings. This year, we've raised our fundraising target to 300,000, and this will rise further to 350,000 by 2022 to develop and extend the service in the areas of education, support, and research, with the ultimate aim that everyone affected by a form of rare dementia will have access to specialist information and support, as well as contact with other people with a similar condition. We apply for grants from grant-making trusts, foundations, and livery companies, and have a wonderful group of supporters, some of whom are here today, who fundraise for us in an amazing variety of ways. We would love it if you would like to sign up to our RDS fundraising newsletter to hear more of these stories and receive news of how we can support this community. We have had people do head shaves for us. We have had a gentleman drive across the Mongolian steppe in a VW Polo, and we have lots of people who take part in runs and virtual runs as well. At the end of February, we held a gala dinner called Mission Possible, where we raised 110,000 for the expansion of rare dementia support. And we are delighted to announce that in line with this expansion, the charity is committed to raise up to 7 million to create the world's first centre of excellence for rare dementias. If anyone would like to discuss any fundraising ideas or the new capital appeal, please do feel free to email me or my colleague Alexis, our Senior Fundraising Manager, who will speak about the innovative new ways you can be involved in fundraising for RDS, even during this challenging time. Thank you very much.
Hello, my name is Alexis Gebby, and I'm the Senior Fundraising Officer at the National Brain Appeal. I just want to start off by saying a huge thank you to all of you who already fundraise for RDS. We really appreciate all of your incredible efforts, especially at this difficult time. My role at the National Brain Appeal is to look after all the amazing people taking on various fundraising activities for us. We have had people challenging themselves to run marathons, cycle long distances, climb mountains, and even take on skydives, all whilst raising money for RDS. We also have wonderful fundraisers out in the community who organise golf days, hold coffee mornings, host choir and carol concerts, and even shave their heads. These people ensure that more people like you can be supported through rare dementia support. If you're interested in becoming one of our fundraising heroes, then please do contact me. I am here to support you with your fundraising, and I'm more than happy to chat about any ideas that you may have. While at the moment it isn't possible to take part in a sporting challenge or hold a big fundraising gathering in your local community, we do have some fundraising ideas, such as taking on a solo virtual run or walk, hosting a quiz for your friends or family online, asking for birthday donations in lieu of going out, or even donating money that you may be saving by not travelling to work or buying your daily coffee. Do get in touch with me if you would like to get involved. In the meantime, take care and we hope to see you soon.